Hi, I'm Erin Schoenfelder-Gonzalez with Outpatient Psychiatry at Seattle Children's Hospital. I'm going to give you an overview of First Approach Skills Training or FAST programs, tell you a bit about where these programs came from and their intended uses, and tell you more about how you can get involved with using them. So FAST is a suite of brief treatment programs for some common child and adolescent mental health concerns. So right now there are 6 FAST programs. We have programs for anxiety, behavior, depression, parenting teenagers, so teen behavior problems, trauma, and early childhood concerns. And you can see that each one is a flexible workbook that is based on a well-established evidence-based treatment. And our team has distilled down the core ingredients of these evidence-based treatments into a flexible modular style workbook. Each workbook is designed to take about 4 full-length therapy sessions or can be broken up into smaller 20 to 30-minute sessions depending on the needs of a given environment. And these programs were created with integrated primary care in mind. So to be used by clinicians who are working side by side with primary care doctors, handing off patients of various ages with a variety of mental health concerns that may be very clear and obvious or may not be so clear. And we've also simplified these programs to require minimal additional training, given all of the burdens that are on providers already in a primary care setting. The other thing about FAST is that all of our materials are free. So you can find all of this at seattlechildrens.org/FAST. Everything I'm going to talk about today, including training videos. So this video is going to give a little overview of the common needs and strategies for integrated primary care and how FAST programs developed out of those needs to fill in those gaps. We're also going to talk about how you can monitor patient outcomes while using FAST, and then we're going to give a very brief overview of what the different programs are all about. There are some additional videos on the FAST website that are trainings for each of the 6 FAST programs. And each of those videos is about 2 hours and goes through the workbook in great detail, talking about the active ingredients of each treatment and some strategies for using the materials with patients. You will see these little prompt logos of a pencil and paper, and those are times for you to pause the video and reflect and kind of think about how something applies in your clinical experience or in your setting. For providers that are within Washington State and working in an integrated primary care setting, we are doing live trainings, which are 2 to 3 hours long. They're interactive and focused on active use of the FAST workbooks. However, if you're not in Washington State, we hope that a lot of our pre-recorded materials will be helpful. And we're also always happy to connect with you and think about how you can get the types of training that you might need. We also offer ongoing consultation for, again, integrated primary care folks in Washington State. And these are calls that happen every other week with a few other integrated primary care mental health clinicians and led by a clinical psychologist that's part of the FAST team. And in those calls, we talk about issues that are coming up related to your work setting. We talk about de-identified cases and strategies for tweaking and applying FAST. And we also talk about other topics that may come up that aren't directly covered by FAST, but where FAST may be applicable. And you can always reach out to us at fast@seattlechildrens.org to talk with us more about your needs or get more information about training. We are working with a large network at this point of primary care stakeholders, and this is our wonderful advisory committee of mental health clinicians who are working in integrated primary care settings. All of our programs are reviewed in an iterative fashion so that we can improve them and personalize them for primary care settings. Directors of FAST are myself and my colleague Nat Youngbloth, and Jennifer Blossom, who's now at University of Maine, is in charge of our research. And we also work with other wonderful psychologists and pediatricians and psychiatrists within Seattle Children's. We are working now with dozens of primary care organizations across Washington state. We are also working with a number of school districts at this point in time and other community mental health organizations who are training in and using FAST programs. So why did we develop FAST? Where did this come from? Dr. Bob Hilt of the Partnership Access Line at Seattle Children's received funding from the Healthcare Authority of Washington back in 2016 to develop programming that would improve behavioral health care for youth through primary care across the state. So we started with a pilot of FAST programming in the Tri-Cities area of Washington state, Benton and Franklin counties, back in 2016. And we started with a community resource model where we trained clinicians in community mental health settings there to deliver FAST behavior and FAST depression and create a rapid referral pathway from primary care practices straight to them. What we found was that the majority of families who connected with these services really liked the programming and benefited from the programming. And clinicians and primary care doctors found this a great addition to regional services. However, we were still struggling to connect with a lot of patients. That handoff to specialty care is a spot where a lot of patients are lost and don't get connected to follow up. So we took away from that we really needed to integrate these programs into the primary care setting in order to truly expand access and improve reach. So starting in about 2018, we started working with integrated behavioral health clinicians across the state. We started our collaborative and our stakeholder committee and have been training and collaborating with clinicians since that time. And we're still doing those trainings. We do them several times per year, and we're continuing to learn from our primary care partners and also work on several directions of research that I'll talk about in a few minutes. Now, although FAST is focused on intervention, it's not focused on assessment generally. We really do recommend that clinicians do needs assessment as much as possible. And a diagnostic evaluation, of course, would be great. We recognize that's not feasible in all settings, but at least working with patients to identify what are the top problems and problems that might reasonably benefit from short-term evidence-based care. And then we can think about whether there are standardized behavioral rating scales that will help us track whether these problems are improving or whether a higher level of care might be needed. We do recommend assessing safety, suicidal ideation in particular, early on in your sessions so that you can devote the majority of time to treatment planning and safety planning if that turns out to be what's needed. And then it's always helpful to know more about current functioning, especially sleep problems, which are huge contributors to every mental health concern, stressors or psychosocial issues that might be addressed in more of a problem-solving approach or working with caregivers or other adults in that child's life. And certainly addressing stressors that might be related to identity, including race and ethnicity, sexual orientation, and gender identity. So this would be a point for you to think about, what are the key pieces that you see as being needed in your integrated setting? How do we make healthcare feasible and accessible and acceptable in integrated primary care? So here's a few of our thoughts. Certainly, we have to have ways of screening and identifying the concerns. Not all of them are going to be brought up in the course of a well child visit. And I know across the state, a lot of practices are now doing universal screening for depression in teenagers, for autism and disruptive behavior or ADHD in younger kids. And that's something that we see as really helpful. We found in our Tri-Cities pilot that, especially for teenagers, mental health needs weren't always brought up in their well child visits. We also need tools that primary care doctors can provide in the session. It's not feasible to provide a course of behavioral therapy, but are there little components of care, lowest level of stepped care that might be realistic? And FAST does provide some of those. And then again, as much as possible, we want to evaluate what's going on and then move on to these brief targeted interventions that are going to focus in on a piece of the concern that can change in a short time frame. We also need to make sure that clinicians and PCPs are interfacing and coordinating care, and that we're monitoring the progress of patients and making sure we can step them up to specialty care if they're not benefiting or if needs are getting more severe. So the Ames Center at University of Washington has developed some amazing models of how to do integrated care in primary care. And this is a little picture of their stepped care model. You can see FAST is focusing more on the lower levels. So giving tools to primary care doctors that can be utilized in session, being able to help the primary care doctor and clinician connect to figure out the appropriate course of action for helping a patient, and then providing on-site brief care, that level 3 there, by a behavioral health clinician. And then stepping patients up to a higher level of care or referring out and helping make sure they get connected when more care is needed. So FAST is designed to address some of these gaps that we've been talking about. We know that the majority of youth who have a mental health problem, including a diagnosable mental health condition, do not end up accessing care. And Black, Indigenous, and people of color are even less likely to be able to access the care that they need. And these communities are very underserved and are needing care that's in a trusted setting, that's more accessible, and that's not going to put additional roadblocks in place. And we also know, including from our own initial pilot, that when we have to refer outside of primary care, those connections do not always happen. The majority of time, they don't happen. So that's another reason why we want to keep care in-house as much as we can. So FAST is a first approach to address needs. These are evidence-based approaches, and offering brief care can then hopefully increase system capacity and preserve clinician time to be able to see more families and help more kids. So we're just going to target, certain mild to moderate mental health concerns, not try to do everything, address everything, but try to make as much progress as we can in this integrated setting. We see measurement-based care as a key component of FAST and any integrated care. And so you might think about how this has been useful to you or would be useful in your setting. And you can feel free to pause the video if you want to think about that a little bit first. These tools, brief rating scales, are great at giving you a snapshot in just 2 to 5 minutes on how a patient or caregiver perceives things are going. And it's nice because we have norms, so we can compare those ratings to hundreds or thousands of ratings of kids in the same age group. So we can see what's a typical concern and what's clinically elevated or outside of the typical range. A lot of these instruments have been designed to reduce bias and to enable people to give more transparent feedback than they might to a clinician. And measurement-based care can also be useful in giving feedback. See, we're making progress on our goal. From your report, things are improving, or things are not improving, or things are getting worse, and we need something else now. And you can also use these measures to communicate with the primary care physician or other treatment team. There are a lot of different options. We talk in each of our FAST program trainings which measures we recommend for certain programs. Here's a little list. We most often use the PROMIS for anxiety, PHQ-9 for adolescent report depression, and the short moods and feelings questionnaire for caregiver report on adolescent depression. And then the PSC 17 is a great measure because there is an externalizing, attention, and internalizing subscale. We also find for teenagers, especially, the strengths and difficulties questionnaire can give a good overall snapshot of mental health and functioning. And then for trauma, we like the child trauma screen because it's fairly brief and not too intrusive and can be a good way to figure out if more of a conversation is needed about trauma. So, in deciding whether you want to treat a certain mental health concern in-house versus referring out to specialty care, you might consider, first of all, that a primary care clinic can't be expected to address every concern that comes up, including every mental health concern. So, what are the priorities? What are the most common concerns in your treatment setting that you might prioritize to start with in rolling out FAST or something similar? You might look at what are easy to access services that are in the local community already that might be redundant with FAST, which of the programs might be the best reach based on prior training that your staff has had. And whether you want to provide a very light touch, just warm handoff and stabilizing in crisis, versus more of a stepped care, actually trying to provide an initial course of treatment in the primary care setting. Here's a picture of how the stepped care is intended to work with FAST. So hopefully there is a screening measure in place. This could be some of the ones that we mentioned. Ideally, this is universal screening, but a mental health concern is flagged during a visit with the primary care doctor. Could also be something the family brings up in session. The primary care doctor can then use our two-pagers, which I'll show you in a second, to provide a little bit of education about that presenting concern and give some initial ideas of things that kids and families can try to make progress. And we do believe there's a subset of patients that can benefit from that education and that very light touch alone. And some of our research is looking further at that, how many benefit from just a little bit of support with their primary care provider. Then the third step would be referring the patient to meet with the integrated behavioral health provider who can provide more working through of that two-pager or provide fast workbook treatment sessions, or can determine if the patient needs to be seen in community care. This is a snapshot of the first part of the anxiety, the FAST A two-pager. So you can see there's a little bit of psychoeducation and a couple ideas of things that the child or family might do to start making progress on improving their concerns. I think it's especially helpful for parents to get ideas of how do we treat anxiety, depression, disruptive behavior, trauma in kids, so they can be using the language and keeping an eye out for concerns that might mean that they need more help. The idea here also is to help families feel more receptive to getting support, instilling some hope that things can help with the concerns they have. We want to share some hot data from one of our partners. Peds Northwest is a 4-site primary care clinic in Pierce County, Washington, that rolled out their behavioral health program with HopeSparks. This is an integrated program in July 2020. And they have kindly been working with us to evaluate their data and look at outcomes. So you can see here that a high volume of patients were referred within that first year period to the mental health clinicians by PCPs, and the vast majority connected. This was really exciting for us to see. This is a much higher connect rate than we get when we refer to specialty care. And patients showed up to these visits. These were short 20 to 30-minute visits, so very light dose in each one, but families were engaged and showed up and kept showing up to receive their FAST treatment. And again, this is not a randomized trial. This is real world data, but looking at standardized rating scales from the first session to the last session. So whether there were just 2 sessions or whether there were 20 sessions, it was very exciting to see there was large change in these standardized rating scales, large improvement. And you can see this third column here says effect size. And an effect size of 0.8 is considered large. So you can see that on the PSE 35, so behavior overall improved to a high extent, as did anxiety on the scared. And then we see moderate improvement in depression and on another anxiety rating scale. These are very good effect sizes for behavioral intervention in general, and very encouraging to us that we're seeing clinical improvement through the use of the FAST programs in integrated primary care. We have a lot of programs that are ongoing. We're continuing to develop additional treatment materials, supplemental materials, and our partners across Washington State and beyond are piloting cases and giving us feedback on how to improve our approach and our workbooks. We have a few R01s that are using FAST and will be able to share some robust data with us about how this works in more of a controlled, randomized setting. And we're working with the CoLab at University of Washington to ensure that our FAST manuals are acceptable and sensitive for patients of a large variety of backgrounds. We'd love to chat with anyone else who's interested in working with us on research or using these programs. At a glance, FAST Anxiety is designed for a wide age range, and you'll see that there's both a child and an adolescent workbook. And so this is for anxiety that is starting to interfere with the patient's well-being or their life. They may be avoiding situations that are where they're expected to interact, worrying a lot, experiencing sleep disruption or more physical complaints. And this is exposure therapy, one component of cognitive behavioral therapy, where we support patients in using brave practice to confront situations that are stressful and retrain their brain that they can do it and they can stay with it and be prepared to deal with challenges that come up. It's also talking about realistic fears, of which there are many, especially in our current world, and how to make plans and deal with those worries when it's not an irrational worry, but something that could actually happen. Fast behavior is not specific to one diagnosis, but this is for kids around ages 4 to 11 who are having acting out behaviors, oppositional behaviors, ADHD, or relationship problems with caregivers or other family members. And this is parent behavior management training, a very well-studied behavioral intervention where we teach parents to use positive relationship building skills to connect with their child and shape behaviors through differential attention, giving lots of positive reaction to what we want to see and giving less attention to the behaviors that we don't want to see. And also setting limits and using contingencies with behaviors that are not okay or that really need to be addressed. Fast depression looks at certainly clinical depression, but also lower levels of irritable mood or lack of enjoyment, isolation and social withdrawal, which we've seen just skyrocket since the pandemic. And this is behavioral activation therapy. The idea being that if we can get people to engage more in their activities of daily living, including getting out, sleeping better, doing something proactive when they're feeling stuck or really down, and taking active steps to problem solve and make progress toward their goals. This also includes support for caregivers to talk with their kids about depression and be supportive. Fast parenting teens is also not specific to one diagnosis. This is designed for middle school and high school age kids and focuses on helping parents communicate effectively with their teens, dealing with big emotions, conflict and arguing, and kids not respecting home boundaries or expectations. There's also some content specific to issues around homework and issues with aggressive behavior in the house. And this is a combination of behavioral parent training and also emotion coaching. and helping parents be effective in not fueling the fire when there's conflict, and creating clear limits and contingencies around behaviors that they want to see and don't want to see at home. Fast trauma is designed for ages 7 to 18, and this is for kids or teenagers with a history of trauma of some type that is related to some current mental health symptoms or difficulties. So, a diagnosis of PTSD is not needed, but it's certainly appropriate if there is a diagnosis. This could also be for kids with depression or anxiety where there's a trauma component. And this is based on cognitive behavioral therapy for trauma. So, a lot of education for kids, teenagers, and caregivers, and a menu of different skills that the youth can choose to do a light touch or a little bit more in depth touch into processing and understanding that trauma and the way that emotions, physical sensations, and thoughts have been affected by what's happened. Fast Early Childhood, our newest program, is designed for kids in that range of 1 to 4 years old. And it has a developmental focus. There's some similarities to Fast B, but it's focused largely on that parent child connection using tuning in skills and emotion coaching. Dealing with tantrums, which is often one of the most common things that parents of toddlers and preschoolers are bringing up to their primary care doctors, and dealing with other specific challenging behavior, including aggression. There are also some specific materials on bedtime and sleep problems, as well as developmental delays and how to think about and support families who have concerns about delays. So, where do you go from here? Certainly start by visiting the FAST webpage where you can download the two-pagers and the workbooks and a lot of supplemental materials. You can also do the pre-recorded 2-hour trainings there. If you're in Washington State and in integrated primary care, you can register for one of our live trainings and reach out to us at this email address with needs or questions and to register. Or if you're outside of Washington and you want to talk more about options, we'd love to hear from you and share as many ideas as we can. Thanks for joining me, and we look forward to seeing you at one of our trainings or hearing from you.